Okay, and with that, we have wrapped up our break. So I am thrilled to welcome Dr. Nicholas Carleton, who is our 2020 recipient of the Royal-Mach-Gaensslen Prize for Mental Health Research. So, Dr. Carleton, I will hand it over to you.
Terrific. Thank you very much. I'm delighted to be here with everybody today. And I'm going to be talking a little bit about some of the work that we do very broadly in my lab and with my team here at home and across the country for public safety personnel mental health. I don't have any disclosures. We are situated at the University of Regina on Treaty 4 lands with a presence in Treaty 6. And I really do want to echo my colleagues in emphatically thanking the Royal-Mach-Gaensslen Foundation for their incredible support and for the ongoing award and the prize system that they built. That's fantastic. When we're talking about public safety personnel, we're talking about a broad range of professionals. And quite often we think of first responders, so paramedics, firefighters, and police officers. But in addition to those first responders, we also have a host of other professionals who regularly work to serve and protect all of us as part of our communities. In Canada, there's about 350,000 of them working at any given time in order to protect all of our well-being. That means we've got about 13 per 1,500 Canadians. And I flag this because quite often people, I think, have a misinterpretation that we have an overwhelming number of these people who work so readily 24 hours a day, 7 days a week. We actually have relatively few of them. And as you can see with the depiction here, we actually have far fewer than we might like to have. And unfortunately, these numbers are dwindling as of late as a function of a variety of the challenges that they're facing. Public safety personnel broadly have a lot of challenges, specifically with respect to things like the general public. So a member of the general public might be exposed, like myself, to 1, 2, 3, 4, maybe 5 potentially psychologically traumatic events. So events that might meet criteria for part of a diagnosis towards something like post-traumatic stress disorder. We might be exposed to 5 or fewer of those in our entire lifetime. But a member of our PSP community could be exposed to 5 of those in a single shift. So they're being exposed to potentially psychologically traumatic events, orders of magnitude larger than we are, thousands, tens of thousands in a single career. They're also different than our military. It's not a matter of better or worse, it's a matter of different. So our military are taken from a safe space here at home and deployed to a very unsafe space elsewhere. And then they're brought home to a safe space here at home. With our public safety personnel, the deployment is quite different. We take our public safety personnel and we deploy them to what for them is an unsafe zone. And we deploy them there with their friends and with their family members. And we've known since the end of World War II that we shouldn't deploy our military to unsafe zones for more than 240 days, to high stress zones, because 100% come back symptomatic. With our public safety personnel, we actually deploy them to those unsafe zones for up to 25 years. They're also different relative to each other with respect to what we're asking them to do when serving all of the rest of us, including protection, enforcement, rehabilitation. They're different with respect to the kinds of deployment we're asking, the kinds of exposure they're going to encounter, the responsibilities they have to our communities, and the certainty they have when they're engaging with us. They're also different relative to history. We're increasingly asking our public safety personnel to fulfill more and more complicated roles, often overlapping roles, in order to provide us the services we've come to expect. They're facing a variety of different mental health challenges as a result of the service that they are providing to all of the rest of us. So data we collected in 2017 provided us with a very initial glance into the challenges that they're facing. And what we were able to identify, thanks to a very large team at that point, was it was nearly 1 in 2 of our currently serving public safety personnel who screened positive for 1 or more mental health disorders. That was in addition to estimates of at least 10% of our public safety personnel being on leave for mental health related challenges at that same time. We were able to update some of that data thanks to the National Police Federation to assess our RCMP in 2023. And as you can see here, we've actually seen a substantial increase in the proportion screening positive, such that now nearly 2 in 3 are screening positive for 1 or more mental health disorders at any given time. So this is a massive challenge facing our currently serving public safety personnel, and we need to help address that challenge. It extends to challenges that they're reporting with difficulties for things like suicidal ideation, planning, and attempts, which are the best predictors that we have that someone might die by suicide. You can have all 3 of these and never die by suicide, or you can have all 3 of these just once and die by suicide. One of the challenges that I want to highlight here, though, is the relative differences that we see for our public safety personnel as compared to the general public. It's as many as 1 in 10 of our paramedics who will attempt to die by suicide at least once during their lifetime. That's an astonishingly high number. And these numbers that we have don't reflect the actual data because all of these are based on self-report, which means anybody who's died by way of suicide is unable to participate and therefore is not counted in the data that we have. They're also facing challenges that have become exacerbated since the COVID-19 pandemic. They were always facing stigma-related challenges, but those have become compounded as a function of challenges related to demand for increased service. We're also seeing challenges with respect to how the media encounters and engages with our public safety personnel. They're experiencing ongoing fallout from the COVID-19 challenges that caused a massive increase in demand on their services that is related to increases we are seeing in things like burnout, as well as increases in things like difficulty recruiting new public safety personnel and retaining existing public safety personnel. These are real-world challenges that are facing us in real time, and they actually impact all of us. But we might not notice the potential impact until we call 911 and ask for help. In an effort to try and address the mental health challenges that are facing our public safety personnel, there are a host of different programs that are currently available, hundreds that are being proffered all across the country at any given time by a variety of different groups. Unfortunately, the best data that we have right now suggests that despite there being extensive programming, there's relatively little research. You can actually look up the hundreds of programs that are currently available at psbmentalhealth.ca, and you'll be able to scan through for yourself and identify the options that are available, and unfortunately also identify the significant limitations with respect to the evidence base. The data that we do have suggests that the available interventions that are most commonly deployed are either lacking with respect to the research evidence that we would like to see, or when we look at things like single session resiliency interventions, the data that we do have available suggests these produce small, temporary improvements in mental health symptoms or resilience or work engagement or mental health knowledge and mental health stigma. But those improvements don't tend to last very long. And as I said, are sometimes statistically significant, but are not necessarily clinically meaningful. All of this is compounded by challenges with skills in general. When we provide training or interventions to support our public safety personnel, and with the idea that we're going to proactively protect their mental health, there's skills that we're usually providing them, or education or systems that we're giving them. And unfortunately, skills decay, as we know, over time, and skill development takes time. There's been expanding research efforts over the last 5 years, some of which I've had the privilege to be party to, but there's a tremendous and growing number of researchers, clinicians all across Canada who have taken up the task of trying to improve the research gaps that we have and provide better services for our public safety personnel going forward. So I'm very excited about what we've seen in the last 5 years. And today I'm going to showcase one of the major studies that I have the privilege to be engaged with, thanks to the Royal Canadian Mounted Police. This is a large-scale, longitudinal investment that involves dozens and dozens of people who probably don't get as much credit as they deserve. But I do like to just take a second and highlight that projects of this size and scale don't just happen. They require massive teams. The RCMP study was a large-scale investment by the RCMP to develop state-of-the-art infrastructure for ongoing self-monitoring and screening, to develop a state-of-the-art evidence-based emotional resilience skills training program that would help provide proactive support and mental health maintenance for RCMP officers going forward, and to see whether or not we can move away from depending solely on self-report and clinical assessments to perhaps use biometric tools to assess mental health to help people get ahead of the challenges that they're facing. All of these were put together as part of a very large-scale study that we rolled out called the RCMP study. We're using a cohort study design because the RCMP wanted to begin at RCMP Depot Division here in Regina. And the Depot Division restraints are such that a true randomized controlled trial was simply impractical. So we start with RCMP cadets who are joining the cadet training program, which lasts 26 weeks. We follow them through until post-training, just at pre-deployment, and then we follow them for 5 years thereafter. We're working with two separate teams, a team that received standardized training and a team that received augmented training. The assessments that we provide begin at pre-training and are a large-scale milestone assessment that is multimodal and involve clinical interviews and surveys that are quite extensive. We then repeat that same full assessment just before they're deployed, and then we repeat that same full assessment on their deployment anniversaries for 5 years after they're initially deployed. Those large-scale assessments provide really important baseline data that's allowing us to assess the relative impact of training and service and the impact of the new intervention and training system that we've helped build for the RCMP going forward. In addition to those milestone assessments, everybody who's participating completes a monthly survey that takes about 20 minutes and screens them for major mental health disorders, providing them with near immediate feedback so that they have an ongoing set of tools that allow them to understand where their mental health is at any given time relative to robust and well-established assessments of mental health. We also have everybody complete a daily survey. And that daily survey is an ultra-brief questionnaire that allows people to reflect and report on 13 factors from mood to physical activity to sleep patterns to substance use. And that ongoing engagement serves as a daily assessment that they can do themselves. It takes about 60 seconds for them to do, and again, provides them with ongoing feedback in live reports and symptom tracking that allows us to work towards trending information and ultimately to produce nudges that work very much like physical assessment nudges. So if you're using a Android watch or an Apple watch to monitor your physical activity, you get nudges regularly to promote better mental or physical health. We're building towards doing the same thing with mental health. The last piece is a daily biometrics piece that we do that takes, again, about 60 seconds. We worked with a cardiology team here in order to really get a handle on whether we could assess something that was a very large indicator of the autonomic nervous system, like heart performance, and correlate that with things like mental health, to either identify mental health injuries have occurred or hopefully to predict mental health injuries or identify them very, very early on in the life cycle and service cycle of an RCMP officer. This also provides immediate feedback right now about their physical health, and we're building trending information that helps to speak to their mental health. All of this results in individualized reports for each one of the participants that allows them to actively engage with their mental health in near real time in ways that we really haven't been able to provide as support tools at any time before this. So people are able to identify patterns and changes in their own mental health on a daily and a monthly basis. It allows us to provide cueing information to support their mental health going forward. It also allows us to screen their mental health using established screening tools so that people can identify that they've had a mental health injury and reach out for mental health supports earlier than has been possible before. So on the right-hand side of the screen there, this is a real-world example of an actual participant who somewhere between June and July experienced some kind of a mental health injury. And as a function of experiencing that mental health injury, their major depressive disorder symptoms jumped. Fortunately, the system was able to flag this and identify that there had been an increase and identify that the increase was likely to get closer and closer to a clinical cutoff score and recommend that they reach out for mental health supports, which in this case is what they did. And they were able to get their mental health challenges back under control, never having screened positive for major depressive disorder, despite having experienced something that resulted in what we think was a mental health injury. One of the showcase pieces of the RCMP study was developing emotional resilience skills training. So the RCMP wanted an evidence-informed training program that could build towards an evidence-based training program as a function of the RCMP study. We were very fortunate to work with the Unified Protocol team down in the United States, who were quick to respond and provide us with tremendous support so that we could build a training version of the Unified Protocol for the transdiagnostic treatment of emotional disorders and integrate that all throughout the 26 weeks of the depot training program. So the Unified Protocol is already robustly evidenced as a very effective treatment. We also had some early data that suggested that it could be used proactively to mitigate post-traumatic stress injuries or other mental health challenges. And so we were able to collaboratively integrate this in a way and at a depth and at a pervasiveness that we haven't seen done before. So we're very excited about the pending results we'll have there. I'm going to cover some brief highlights for what we've already learned about RCMP mental health that we can then extend to other groups. If you're interested in learning more, you can find this information available on our website. What we know here was able to provide some important myth busting for RCMP. First of all, there's a long-standing myth that part of the challenge was we were just hiring people who had too many mental health disorders to begin with, or people who weren't resilient enough to begin with. Well, the RCMP cadets start their cadet training program with better mental health than the general population. And we already know, thanks to research that's recently accepted and now in press, that they actually complete their mental health training with even better mental health, which means that their mental health is actually already as good or better than we might hope for by the time they're being deployed to service. We also know, thanks to research that we've completed with the data so far, that it already starts to decay after a single year of service. And so the data is dramatically pointing us in the direction that, as we had thought before, the problem isn't that we aren't hiring mentally healthy people. The problem is that we are asking them to perform extraordinary amounts of service, and their mental health is suffering as a function of that service to their communities. We also know that based on established putative risk and resiliency factors from a variety of other mental health research studies done all around the world, the RCMP cadets start with higher levels of resiliency and lower levels of risk than the general population by statistically significant amounts. That is further improved by the time they are ready to deploy from depot. So this again underscores that the problem isn't that we are hiring people who are not resilient or people who are at particularly high risk, but instead that we are seeing that very resilient, highly adaptable individuals are having challenges as a function of the services they're providing. We also know that their personality profiles are actually quite consistent with what we would hope for contemporary personality profiles for our CMP and other police officers. So they have higher scores than the general population on a variety of things that we believe are important going forward for policing in our contemporary communities. We've also been able to demonstrate that the self-monitoring system does exactly what we would expect based on other data. When we engage in self-monitoring of our mental or our physical health, the monitoring in and of itself typically helps to improve our physical or our mental health by helping us stay aware of choices and make better proactive choices going forward. So the evidence that we've got so far suggests that completing as few as 2 of those daily monitoring surveys each week is associated with better mental health. And as few as 1 every approximately 2 to 3 months of the monthly surveys is associated with better mental health, even after controlling for a variety of other variables. We know that regular self-monitoring is also consistent with longstanding recommendations for things like safeguarding models for any group that's going to be regularly exposed to particularly challenging psychological stressors. This has allowed us to create an electronic mental health record system that sits independently of any other system safely in the university system, and that is also consistent with safeguarding models. It produces clinical dashboard information that the users can export at their own accord and take to a clinician of their choosing to provide really important historical mental health data that can help with ongoing assessments and treatments when they need them, literally facilitating the kinds of clinical supports that we need going forward. In addition, this allows us to potentiate aggregated, anonymized dashboards at a system level. So imagine being able to actually, in real time, look at and look after the mental health of an entire community of public safety personnel, such as our RCMP officers. And that's what we're in the process of moving towards right now. It's an important next step that we think is going to allow us to support responding to protecting PSP mental health in near real time, again, in ways that we haven't been able to before. We think it's also going to allow for improved research and assessments of a variety of interventions and training programs that are being proffered so that we can maximize the potential gains for all of our public safety personnel. And indeed, thanks to additional research funding that we've received from the Canadian Institutes of Health Research, we've been able to demonstrate that you can take and adapt the tools and the training that we've built for the RCMP to a diverse population of public safety personnel. And we see the same kinds of results that we've seen for our RCMP with respect to self-monitoring, and we're seeing very, very promising and exciting results with respect to the mental health training program. All of those will hopefully be available in the coming months as we complete some of the peer review processes. So coming soon for our next steps, we're going to have ongoing results from the RCMP study and that extension study that I mentioned, where we were able to take the tools and training to other public safety personnel. We're about to update several of the national prevalence estimates for our municipal and our provincial police and our firefighters, thanks to some funding that we've been generously provided by a variety of institutions. And we're going to be exploring a multi-agency collaborative provincial mental health monitoring pilot that will launch in 2025. So I think if I can leave you with a few take-home messages about the research that we've been able to do over the last 5 years, our public safety personnel are facing many more challenges than most of us recognize or realize. Ironically, the better they do their job, the less likely we are to understand how difficult their job is. We really do need to build and support cradle-to-grave evidence-based systems to support all of them in supporting all of us, because we all really do depend on them so often and in so many capacities. These solutions need to involve individuals, families, stakeholder organizations, and the public to make sure that they are there for us when we need them going forward, by us being there for them right now. So thank you very much for your time. I hope this was informative, and thank you very much for providing support to all of our public safety personnel going forward.
Well, thank you so much, Dr. Carleton. That was very informative and interesting. So now we will move on to our 2021 recipient, Dr. Simone Vigod from the University of Toronto, who will focus on tackling the gaps in perinatal mental health care, an evaluation of a pregnancy and postpartum mental health optimization virtual intervention network, aka MOVIN. So I will hand it over to you, Dr. Vigod.
Okay, can you hear me all right? Great. And you can see my slides? Okay. So thank you very much for having me today. I'm really thrilled to be here, and just want to say that I think the themes of prevention, the themes of improving care, the themes about the generational transmission of mental illness and a life course or lifespan approach have really threaded throughout the day. So I'm glad that I can continue along that theme. And what I thought would be fun for this presentation was to take the idea about the funding from something like the Mach-Gaensslen prize. I really thought of this as similar to what Dr. Fifi said. What could be something that's really difficult to find the funding for elsewhere. And so, sometimes you have this idea and ideas and you need some seed funding before you can bring them to reality. And so I thought it would be fun to talk about MOVIN, which stands for the Pregnancy and Postpartum Mental Health Optimization Virtual Intervention Network today. So I hope that you enjoy. Of course, like everyone else has said, this presentation and this project has involved a huge team of people. I receive royalties from Up to Date for authorship of materials focused on depression and pregnancy, but no other conflicts. And the research discussed today has been funded from a variety of sources. So I am a psychiatrist. I do women's mental health work in a specialty clinic in Toronto, and a lot of the work that I do focuses on the time around pregnancy, where really this is a unique life stage because mental illness around the time of pregnancy poses unique challenges, but also really unique opportunities where we have the ability to impact not just one person, but also their children and families. And perinatal mental health issues are probably, after you take into account maybe postpartum bleeding, are probably one of the most common complications of pregnancy. And there are about 400,000 births in Canada every year. So if you do the math, 20% of 400,000, that's about 80,000 people pregnant, postpartum, and their families each year who are affected by these issues. And it really does matter. It matters for the well-being of the person who is affected. It matters for the growth and development of a fetus, of an infant, of the parent-child relationship. There are associations between untreated or undertreated mental health issues in the mom and developmental issues for their children. And we've already heard about some of the genetic issues. And then, in very rare cases, we do have very serious outcomes that come out of mental illness around the time of pregnancy. And in fact, in countries like Canada, where direct causes of maternal mortality, are quite low, something like suicide ends up being a major cause of death. So anything that we can do to prevent and treat perinatal mental illness can have a really, really large impact. The good news is perinatal mental illnesses are highly treatable. People who have maybe milder symptoms often respond really well to interventions that we've heard about today, like peer support, co-parenting interventions to reduce stress, Even there are some home visiting models for support that have evidence. When people have slightly more severe symptoms, you're looking at highly evidence-based, highly effective psychological treatments. And when people have more severe illness, we're starting to think more about medications and other illnesses. But in general, perinatal mental illnesses are highly treatable. The problem is there's a gap between what we know works and what we are actually doing, because in Canada and around the world, it looks like as few as 1 in 5 people affected receive the care that they need to be treated to remission. There are many reasons for this that start with lack of knowledge or lack of belief and a myth that, pregnancy is protected and against mental illness. People not being, people feeling, I wanted very much to get pregnant, have this baby, like I shouldn't be, saying that there's anything wrong or that I'm not doing well, right? And then there are a lot of really practical barriers to care, including not having enough money, having to put in all your hours before your baby's born, when you're pregnant, childcare, travel barriers. But one of the biggest issues that we deal with are, long waiting lists and lack of specialized care in certain regions. And in a survey that one of the advocacy organizations in Canada, the Canadian Perinatal Mental Health Collaborative, did, they found that 40% of Canadians were saying they were waiting 2 months or more for access to treatment for their perinatal mental health problem. And you might say, well, that's not a big deal, but 2 months or 3 months, like that's most of pregnancy, or that's like, a quarter of a child's, first year of life. So, and then even then we don't know exactly what treatment they were getting. So the question becomes like, what do we do about it? In fact, there are across Canada many community-based programs that offer education about perinatal mental illness, that offer psychosocial interventions. I've listed some of them here. There are also lots of individual providers who have specialized training in psychological treatments or in psychopharmacology. It is true that many people who have expertise in the perinatal psychological treatments are not necessarily funded by the public funder. So that's a barrier. There are about 10-ish specialized perinatal mental health programs that offer all of the steps of care that I showed, kind of from the mildest level to the most severe. But these are primarily in academic centers. So we've sort of got this situation in Canada where we've got all of these different services, but we haven't necessarily brought them all together to rationalize them, to say, okay, how do we, in Ontario, everybody, for example, could be referred to my clinic, right? But it kind of depends on, does your doctor know about my clinic? And so we have maybe all these people thinking they might need specialized care, maybe they don't. And we don't even really know, do we not have enough services in Canada? Or do we actually have enough services, but maybe we need to streamline and organize things a bit better? So my key question, for today is, what would it take for all Canadian women and gender diverse birthing people to have access to what they need to have timely and effective perinatal mental health care? So I don't claim to have the full answer to that question, but I thought that it would be neat today to talk to you a little bit about how our group has been thinking about this, and one of the interventions that we developed to tackle this key question. So MOVIN is a mental health web-based platform where perinatal people can access evidence-based and stepped care treatment for depressive and anxiety symptoms. And what it is it's a coordinated jurisdictional approach. So essentially it's patient-facing, so patients can come in, enter the system through one door, and a way for them to get what they need. It sounds simple, but we've been working on it for a number of years to try and get it to actually operationalize. So what it is it has a curated knowledge center where people can learn and get resources. They can then self-screen for their symptoms and get some feedback on that. They can then connect with a care coordinator who is not just a care navigator, but is someone who's doing, like in a collaborative care model for mental health, someone who's doing short problem-solving therapies, understanding, what kind of, mild, moderate, or severe kind of treatment do people need, incorporating their history and their treatment preferences, and then having oversight from a reproductive psychiatrist who can work with the care coordinator and the patient's primary care team. And so in the pilot study, we've actually updated it for our next study with new colors, but there's a knowledge center and resources that our team has curated, can be filtered. And then people could self-screen on the app or website. And we use the Edinburgh Postnatal Depression Scale, which is a validated symptom scale to try and detect and also monitor the severity of perinatal depressive and anxiety symptoms. And then they get some explanation of what their score might mean. And then they can also fill out a profile with them, which I'm not showing you here, but then they can schedule a call with one of our care coordinators who then works with them to figure out, are there additional resources they might want to learn from the Knowledge Center, and can put them into their care plan. Helps them arrange and access the community accessible treatments that they can access themselves. So the one that's showing on here is an online group therapy program that we happen to run out of Women's College Hospital, but it's an evidence-based online group therapy program that they can self-refer to. And then if needed, the care coordinator can also help liaise with the primary care team around, maybe this person, might benefit from a first-line medication, and then arrange for psychiatric consultation and care in more complex cases if that's needed. And then the other piece, which is really, really important when you think about collaborative mental health care type interventions, is follow-up. So again, through the app, they can have their symptoms rechecked. And then if they're not improving, they can go back and speak with the care coordinator, and they can make adjustments to their care plan. And so sounds simple enough. I can tell you we worked with a lot of people over a long time to get this streamlined and get the resources, all right. But we ran a pilot trial to assess the feasibility and look at some preliminary efficacy. And so we recruited 101 participants. One thing I can say is we recruited people so fast. We didn't even have to pay for advertising. We just put it out, on a few listservs and on our website. And people, they would have had a 50% chance of being randomized to the control group, right, which was usual care. And, it just shows you how much people are really needing this kind of coordinated care in this population. And so in the MOVIN group, most people logged into the platform. All of them completed, at least one follow-up EPDS. The vast majority had a call with the care coordinator. And what I think is the most interesting piece of the whole thing is that only twice did the MOVIN psychiatrist have to do an e-consultation with the primary care provider. And only 3 times did the MOVIN psychiatrist do a direct consultation with the patient. So what that's essentially saying is, the 4%, the 6%, like for every 100 patients, they don't all necessarily need to go to specialty care. And when we looked at the remission rates at the end at 12 weeks post-randomization, we had a 20% differential in the remission rates between the MOVIN and controls. And then a 25% differential with 75%, 3/4 of the people in MOVIN were better, were in, quote unquote remission for this study at 6 months post-randomization. And what's amazing about this is most people on this call would know, like, that's probably a better remission rate than you would get with an antidepressant. And if you think about it, MOVIN didn't even provide them with a specific treatment. We directed them, we supported them, we got them, the information that they needed and the advice that they needed. So we've been really, really excited about this. And based on the findings, we started working first in Ontario to see, could we scale this up to the whole Ontario jurisdiction? And we got on board the 5 big comprehensive perinatal mental health programs in Ontario to say, okay, like let's do this. We'll have patients come, the care coordinator, psychiatrist support, and then only if they need to be referred into one of the 5 specialized programs, we'll streamline them to doing so. And the psychiatrists from those programs will be a roster for, supporting MOVIN. And we will use, existing community-based resources in Ontario to do this. So we applied to CIHR and we were funded about, I think, 1.5 something million to do this. And it looks like we're going to launch in April or May. And so we're pretty excited about this. It's going to be about 600 people. And really the idea is to see, does this work, and also do a lot of work around implementation. And we have, advisory people on the advisory panel from the rest of Canada and decision makers to think about, if this works, how could we scale this up across other jurisdictions? So, I could have talked about many things today. I did just want to say, make sure everybody knows how common mental illness is around the time of pregnancy, such that even small improvements can make a large public health impact. And hoping that, in this case, we will be able to, look at how do we close the gap between the things that we know work and what we do for the patients of today, while we're also, continuing to do biological, psychological, and social research, to improve outcomes for the patients of tomorrow. So thank you very much.
Thank you so much for that. It was very interesting, and such an important topic, because, as you said, so many people are living through that. So thank you very much, Dr. Vigod. And now we will move on to our 2022 recipient, Dr. Sheri Madigan, who will cover transforming research into action, collaborative and socially innovative solutions for child maltreatment and mental health. So over to you, Dr. Madigan.
Thanks so much. I really want to begin by expressing my gratitude for organizing this, and to the Royal-Mach-Gaensslen Foundation for really the honor of being an awardee of this mental health prize, and for prioritizing mental health research in the way that they do. And I also want to extend my admiration for the work of all the other 9 awardees over the last decade. It's really a privilege to be here with you today. It's also nice to come back a few years later and hear all the updates that everyone's doing and have an opportunity to share that. So one of the things I just wanted to say was, while I was a recipient of this award, and I'll talk about the work that I've done a little bit since then, the work I will present today is really a result of exceptional teamwork. I have a real, it's a real collective effort. Graduate students, undergraduate students, postdoc, fellows, community partners, and funders. And they have all contributed in really invaluable ways, and I get to be here and present on our behalf. Like Simone just mentioned, I'm going to present just a tiny branch of my research today in the 15 minutes that I have, but I've been fortunate to lead lots of different types of research on the determinants of child development, and all that, if folks are interested, is on the website, and they can go and learn more about it. There. And I'm just gonna make sure my slides are okay, and I'm assuming I would hear otherwise from Michaela if not, but I'll just keep going.
Great.
Okay, great. Also wanted to take a moment to acknowledge that the land I currently call home is Calgary, Alberta, where I live, work, and play as an uninvited guest. This land is situated on the traditional territories of the peoples of Treaty 7, and Calgary is also home to the Métis Nation of Alberta, District 5 and 6. This iconic photo is one I hope some of you have had an opportunity to see in your lifetime. It is Moraine Lake in Lake Louise, Alberta, which is about 2 hours from here. And it's a breathtaking landscape that reminds us really of the deep history and connection that Indigenous peoples have had with this land for many, many, many generations. So my talk is really going to be framed around this quote right here, which really, I think, embodies the central themes of my work. So I love research, and I love data, and I love doing all types of analyses, but as a clinician scientist, I'm really pushed to apply that research and to really think deeply about the impact, the activities, and the output of the work in terms of how, we are shaping people's lives. So knowing is not enough, we must apply, and willing is not enough, we must do. A lot of the work that I will talk about today comes out of my work as a clinician, as a clinical psychologist, where I worked with families doing trauma therapy with primarily children who had suffered from some really difficult childhood experiences. So I focused my time on that particular branch of my research because it emerges from both my research world, but also from a lot of the questions I ask actually emerge from the clinical work that I do. So at the core of the research in my group is really a commitment to both understanding and supporting children's mental health trajectories. I'm particularly interested in the determinants of these trajectories and what really can support some children to develop really optimally, and in other cases can actually derail children's development, and to try to find out why that might be the case. So the reality of children's mental health in Canada is that 1.6 million children currently have a diagnosis in Canada. That's 20% of our children in Canada. It's quite a startling statistic. And unfortunately, very few children who are struggling to the point where they really need services for mental health are not getting those. So only about a quarter of the children who are in urgent need for mental health supports are getting the support that they need. So it really, I was really inspired by some of the talks I heard about like trying to think innovatively about how we can respond and adapt to these needs so that we can actually reach more children and give them services and supports that they might need. One of the primary contributors to mental health challenges is abuse and neglect. And we heard from Dr. Afifi earlier, who talked about this in adults and some children, and I'll focus on my time on this. Approximately 2/3, 2 out of 3 Canadians are actually reporting that they've experienced maltreatment in their childhood, and that's obviously really concerning. And in a recent report by Canada, Children First Canada, children and parents are actually identifying poor mental health and violence and abuse as 2 of their top 10 threats to their well-being. So I think it's a particularly, these are really important topics, and why in part I chose them today. One of the ways we often characterize some of the ways we talk about child maltreatment is around the Adverse Childhood Experiences Questionnaire, or the ACEs questionnaire. These are items, these are the usually 8 to 10 items, and they're illustrated here. They usually cluster into 3 main categories. So abuse, emotional, physical, and sexual abuse; neglect, which can be either emotionally neglective or physically neglecting; and then what is often characterized as household dysfunction. So these are things like having a parent who's incarcerated, losing a parent, being exposed to domestic violence, or living with a parent who is struggling with really difficult mental health or substance abuse issues. What we know from a lot of research is that when individuals experience a lot of these ACEs, they often they can accumulate in a dose-response manner. So as the number of ACEs accumulates, so as you answer yes to having experienced any one of these items before, or any one of these experiences prior to the age of 18, as those mount, you're more likely to have a dose-response relationship where the outcomes or the consequences of some of those experiences also increase. So an individual who has a higher ACE score is much more likely to suffer from both mental health and physical health problems throughout the lifespan. One of the things that we've done, because these are really count scores of have you experienced these or not, and it's this measure of ACEs is used pretty consistently throughout the world, is we've actually tried to characterize more recently how often these experiences are populations are experiencing these ACEs. So we recently published a meta-analysis looking at 500,000 adults across the world, combining 18 countries, 22 countries, and 206 studies. And we were really trying to characterize how often these ACEs are experienced. And what we found is only 39% or 40% of the population is experiencing none of these ACEs, whereas we're seeing a large number of individuals are experiencing 4 or more of these ACEs in childhood. And one of the things we're interested in is what does this mean for how they're functioning? And What we've done through a series of moderator analyses is really look to see who is also more likely to experience some of these ACEs. So if in the average population, 16% are experiencing four or more of these ACEs, what does that mean in populations who are known to be more at risk? And what we find in these populations that have more risk conditions or greater vulnerability in some ways, we're seeing that they're far more likely to have four or more ACEs than individuals who don't necessarily have these risk indicators. So for example, individuals who are struggling with substance abuse, 55% of those individuals have four or more ACEs, where that's compared to 16% in the general population. So we know that a lot of people that we're seeing clinically and in a lot of our mental health clinics or even our physical health clinics have a really likely high number of experiences of adversity in childhood. And that should really shape how we go about care with individuals at a population level and make it much more trauma informed. So we're going to assume that it's a little bit like hand washing before patient care. We want to actually go into most interactions with patients with a trauma-informed lens, knowing that they could be triggered by different discussions or conversations, knowing that the potential to be re-traumatized is there, and knowing that as clinicians, it's really important for us to both realize the impacts of these adversities and understand how to respond, given the really high likelihood that most of the patients that we're interacting with have had these adverse experiences. So we've been doing a lot of work in schools, in healthcare organizations, really trying to promote the concept of trauma-informed care or trauma-informed approaches to patient care. But what I'd like to talk about now is just a little bit about what we've been doing with all this data. So we run a lot of meta-analyses in our lab, and to accomplish the meta-analyses like I talked about just now, and we replicated that meta-analysis recently in child population samples, we have to review an enormous body of literature to get down to these 206 studies we might have included in the analysis. So we would review 30,000 studies, and then we would screen the full text. That's, the full PDFs of 21,000 articles to get to where we need to get the type of study that we've published. So in order to, we've been thinking a lot as a group how to be more efficient with this process, but also be more be able to share the data in ways with other people who are interested in conducting similar meta-analyses. So what we've been doing is building a data catalog of all studies that have ever been published using the Adverse Childhood Experiences Questionnaire. They have to be empirical, so they've done some empirical tests of the association between ACEs and some predictor or some outcome, or have prevalence data. And we've cataloged all of that data into a very large Excel file that documents each individual study and their results. And what we've been able to do with that is ourselves and my graduate students and my postdocs is conduct meta-analyses. But we really have the goal of sharing that data because we really want to make our data as open access as possible, not just to researchers, but to policies and clinicians who might be interested in the data as well. So we have created something called the ACEs Hub that actually puts all of this data online, and you can find it here. We basically go into this catalog function, and every bit of data that we've cataloged in a really comprehensive and systematic way is now available for anyone to use broadly. So we've consolidated all of the research that currently exists on ACEs. That's about 4,000 empirical studies, all consolidated and put into a catalog function. So here you can see part of what happens on this database and put into a way that people can use. So you're able to filter by topic. So you can see here that because every study is cataloged on ACEs, you're actually able to sub-select the research that you're most interested in, and here every study that currently exists on that topic on adverse childhood experiences, and in this case addictions, addictive behaviors, and genetics will come up here. So 41 of 3,100 studies will be provided here. You're able to click, get the DOI, get the link for that, find out who you might collaborate with. or also just search up what's been done at different institutions. There's a map to show you where it's been done around the world, and really search up any topic that you're interested in. And because we heard from policymakers that they're much more interested in meta-analyses to make policy decisions than individual studies, we've also done the same systematic process and cataloged all studies that have been all meta-analytic studies that have been conducted on the topic. And so you can toggle between these two things. So if a graduate student is interested in finding out if they have a novel idea, they might go on here and find out if the meta-analysis has been done or not. Or if a policymaker is looking to make a policy decision, they can actually get the information quite quickly in this way. We also, on this website, because people may stumble upon it and we want to be trauma informed, have included a variety of information on psychoeducation on ACEs and on how to combat ACEs and how to recover from them, because we really want people to be able to feel empowered to make sort of decisions about their own health and well-being, and that a lot of the time comes from being educated about the topic and learning about how to support themselves. So this idea, this ACEs catalog and putting this online is really spearheaded from a lot of energy and enthusiasm at the University of Calgary for ideas that are really focused on social innovation. So social innovation is really thought of as it's more than just a concept. It's really a process that navigates the intersection of a society's need and a creative and evidence-informed solutions that are effective, equitable, and really sustainable. So the quote here that has been guiding me in many ways is that the power of knowledge is only realized when it's shared and used to create a better future. And that's something that's been driving me a lot as I progress in my own career is it's wonderful to generate knowledge, and I do love science and data and analysis, but I also want to make sure I'm giving back to the individuals and creating a better society in some way. And so this concept of social innovation is one that has emerged recently and I have found particularly interesting and certainly jumped on board with. And here is one more example around that. So it's important to know the knowledge around ACEs. It's also important to apply it, as I've been mentioning. So we have been approached by some agencies that we have as partners with a really difficult problem for them. And that's that children who have experienced really significant abuse and are going to see these child advocacy agencies to get support for the abuse that they've experienced. The parents are in distress. They don't know how to help their child who's having visceral flashbacks, nightmares, sleep disturbances because they've just experienced this acute assault. They're sitting on a wait list for 4 to 8 months with no supports and resources. And so how can we fill that gap in a way where we don't replace treatment, but we actually offer them an opportunity to gather some information around how to support their child and understand trauma so that they can get on a path to recovery and to feel empowered to support their child as best as they could. And so we created together with our partners at the Luna Child Advocacy Center something called COPE. So it's copewithtrauma.org, and COPE stands for the Caregiver Online Psychoeducation Modules. And psychoeducation modules in trauma therapy and in most therapies are really given at the front end of treatment. And it's really focused on telling people, in this case, about trauma, how often trauma occurs, normalizing some experiences, and also giving initial supports and coping strategies for how to get over some of the really tough symptoms and emotional aftermath that can come after someone experiences a trauma. So this, in our hope was that this would provide an interim place for caregivers to go when they're sitting on that wait list. And we're in the process of actually, with youth, adapting this for youth, because it's possible that not all youth will actually have a caregiver who could help them through this situation. So we want to make sure they have a place to go as well. So COPE has several components. It's all based on evidence. It's all evidence informed. And what we really want to do is really provide information about key trauma concepts. So I'm going to play this as an example. The website has lots and lots, like a coping toolbox, and it gives caregivers lots of strategies. And I'm just playing a little clip on how to understand children's, different aspects of children's trauma responses. I'll ask Michaela to tell me if this audio isn't playing, but I hope it is.
I heard it for a second and then it stopped.
A whole range of unsettling experiences. A traumatic experience, like child abuse, can lead to mental health difficulties if left unaddressed. Many parents find it helpful to have an understanding of the causes and the impacts of trauma in order to manage its effects and begin the journey of healing. In this section, you'll find specific information on what is a traumatic experience, what is traumatic stress, what are trauma triggers, the impacts of trauma on a child or youth, and the impacts of trauma on caregivers.
And so for each section, just in the interest of time, I won't go over all of them, but we really just provide lots of information on all the different symptoms kids may experience. We give both written and video explanations of that. And we talk about strategies for talking about kids with trauma to supporting their recovery. And we also talk to caregivers about coping skills for themselves. Many caregivers have their own trauma experiences and can be really triggered by their child's trauma. And so we want to make sure they feel supported in engaging what they need to do to feel mentally ready and supportive of, for their child. Our hope is that we can reduce trauma symptoms to some degree and enhance caregiver self-efficacy and reduce some levels of stress, because we know that when individuals have information, they can feel really empowered to support their child. Again, this doesn't reduce treatment, but we hope it actually might reduce wait times, because some treatments may not need to be as long for each individual child because they have had some lead-up services prior to being on that wait list for a really long time. Our site's already had over 5,000 unique visitors, and it was just launched this year, so there's obviously a need here for these types of resources. And as summed up by one of the parents that we have been interviewing after they've done some pilot work that we've done on whether this can be supportive to them, the most valuable part of the COPE website was the opportunity to co-view it with my daughters. It gave us a common language to talk about trauma, helped us identify and label our feelings, and provided a resource we could revisit anytime. So we've got funding to do an implementation trial for this, where we have this conducted in community centers through a randomized controlled trial over a few years. And we'll also do focus groups with clinicians, because we want to gather their feedback and continue to improve on the site as it sort of goes into various stages of development over the time. That's really integrated through many different partners' feedback, parents' feedback, and practitioner feedback, so we can make it the best resource possible for families. So I'll end by sort of going back to this quote that, knowing is not enough, we must apply, and willing is not enough, and we must do. So this is something that has and will continue to guide my research as I move forward. And again, I'm very indebted to the foundation for their support of this mental health work. I just want to take a quick note to thank my funders and a lot of the partners that are involved in this work, and folks can stay connected with me through these means.
Wonderful. Thank you so much, Dr. Madigan. Such important work that you're doing. So thank you for taking the time to share with us today. And now we will move on to our 2023 recipient, Dr. Srividya Iyer from McGill University, on the Global Youth Mental Health Crisis, Origins, and Ways Forward. So over to you, Dr. Iyer.
Good afternoon. It's really a great privilege to be here today and to follow this very impressive line of speakers. My talk will broadly touch on the two key themes in my research program, the first being to better understand the lives, mental health, and well-being of young people, and the second being to develop, implement research, and advocate for youth-attuned, evidence-informed, culturally and contextually relevant services and policies in Canada, but also globally. I'm calling today from Montreal, which is where I live and work, which has long served as a site of meeting and exchange amongst many Indigenous peoples. And in my own work, I have the privilege of partnering with many First Nations, Inuit and Métis, young people, families, clinicians, community members. And part of what I would really like to highlight, what I've learned from that, is the salience of history, connection to land, culture, and community as foundational to mental health. My work has benefited from funds from various funding agencies, particularly the Canadian Institutes of Health Research and the Canada Research Chairs Program and the Royal-Mach-Gaensslen Foundation, which is why I'm here today. And my work really reflects the contributions and creativity of the very many people I am lucky to work with, many partners and collaborators across Canada and globally, including young people, many students and very creative trainees. And so I have the lucky job of presenting here today, but it is really the work of a collective. In organizing this presentation, I kind of thought of thinking about both looking back and moving forward, and both with respect to my own research program and in thinking about my research program as a microcosm of youth mental health as a field. These two are also about looking back and moving forward with respect to the field of youth mental health. In terms of looking back, if you look at the last 10 decades or more, perhaps the most clear trend is the growing recognition of the importance of youth mental health. And there have been various arguments made to substantiate this increasing focus on youth mental health or the youth mental health concerns and crisis. Part of it is epidemiological evidence that shows that most mental health problems really develop before the age of 25, that young people share a disproportionate share of the disability associated with mental health problems. Part of it is also from the point of view that this is a critical developmental period, and if we can really impact outcomes during this period, you can potentially impact long-term trajectories. So really the promise of early intervention is also about hope. And many of these arguments were brought together in the Lancet Psychiatry Commission on Youth Mental Health that was released in August, that I had the privilege of co-chairing and working with many researchers and young people across the country to bring together both this argument, but also service and policy responses to this growing concern about youth mental health. And what we did, part of what we did in this was bring together data from various countries that clearly showed that with respect to youth mental ill health, there were rising rates or concerns even before the pandemic. So data from Australia, England, UK, Denmark shows this clear pattern all the way from 2007, 2010, and 2015 onwards. Of course, whenever we talk about data, there are some very clear gaps, and most of this data is from high-income countries. So this is something that I will return to as a theme throughout my presentation today. The second sort of clear theme with respect to looking back, and one that is a key feature of my research program, is that there's been massive reform in youth mental health services over the last 2 decades or so. And while this is shaped a bit differently in different contexts, some of the key features of this reform have really been thinking about hope and optimism as foundational, focusing on this age group of 11 to 25 or 11 to 29, 30, rather than the traditional child, adolescent, and adult dichotomy, having a lot more holistic focus. So not only on symptom and symptom resolution, but also thinking about functioning, about young peer relationships, community living. So really having a much more holistic focus, both in terms of outcomes, but also in terms of interventions, and really thinking about low barrier, easy access to services. So these have been sort of the key features of this massive reform in youth mental health services. And perhaps one other foundational feature is the idea that such services need to be co-designed or in partnership with young people, with families, and with other community partners. This has clearly been a key theme within my work and that of many others in this space. And while it may seem sort of intuitive, like why would you do something different, this wasn't always the case in the past. Most of the work, both research and services, was quite expert driven. So this has become much more the norm and the status quo in the last little while, and has also resulted in a wealth of evidence about co-design itself. What is co-design? How does it work? Why do we do participatory approaches? How do we evaluate whether we are doing co-design? What do we need to do as researchers to be able to do this effectively? When it comes to massive reform, perhaps like the poster child for massive reform in youth mental health, one that was really my entry point as well into this focus on youth mental health was early intervention for psychosis. So really focusing on providing high quality care early on during the first 2 to 5 years after the onset of psychosis. With some of the same principles that I outlined earlier. Now there's early intervention services for psychosis in many, many parts of the world, and Canada has certainly been a leader in early intervention for psychosis, and it has been heralded as the most positive development in mental health services since the beginning of community care. Kind of moving and taking inspiration from early intervention, but thinking about using some of those same principles for the broad spectrum of youth mental health. This has really been the shift that we have seen in the last 10 years. In Canada, one of the projects that really spearheaded this movement is the Access Open Minds project, which was funded by the Canadian Institutes of Health Research and the Graham Beck Foundation. And the project focused on developing, implementing, and evaluating a transformation in the way in which mental health services were accessed by and delivered to young people in 16 very diverse communities across the country. So urban, rural, Anglophone, Francophone, remote, 6 Indigenous communities, 1 post-secondary, 1 homeless youth. So really the idea was that we needed to distill core principles that were both informed by young people and other stakeholders' preferences, as well as evidence, but that could really be locally operationalized based on local resources and preferences. And what we found over the last several years in implementing this model and in evaluating is that it does increase uptake, so many more young people sought services. It increases timeliness of services, so many more people got help very quickly. Our benchmark was 72 hours. Many more young people are satisfied, and that this is a cost-effective model. So there's a lot of promise. There's still a lot of work to be done, but this is certainly quite promising. In Canada, we now have massive investments in this primary or community-enhanced youth mental health services, along with many other services that young people might need, like physical health, sexual health, peer support, cultural services, in what are now called integrated youth services. And there are integrated youth services across Canada in each province and territory in various stages of development, as well as a large Indigenous youth mental health and wellness network that's really kind of pushing and asking questions about what outcomes, what measures, what interventions are really needed if we were to improve Indigenous youth mental health and wellness. And this isn't only about improving, but also taking very much a strengths-based focus. And I have the pleasure of working both on Air, which is Quebec's Integrated Youth Services Initiative, as well as this Indigenous network with many partners. The next little while, I thought that I would really focus on sort of moving forward and thinking about, we are at a point where we are building on a lot, but yet there's many things that are at a point of tension. And I think this might be some things to share about. There are many, many topics to talk about in this spirit, but I would probably focus on just 2 in the interest of time. The first sort of important aspect moving forward that we really, really need to be mindful about is that we keep talking about youth as if they are a monolith, but there are many youths. There is no one adolescence. There is no one young person or one way to be young. And part of the problem is that a lot of the work and the knowledge is really being generated perhaps in only certain types of contexts, which leaves much more room for us to think about what are these different ways to be young. So, for instance, while much of the work happens in high-income countries, about 90% of the world's young people actually live in low and middle-income countries. Similarly, in Canada, it's in the Indigenous communities that a large proportion of the population is young. So we really, really do need to expand the geographies in which we are working. And this is not really the case. Part of my focus in the last little while has been on early intervention in low and middle income countries. And this is work that I've been able to advance a lot more because of a PhD student, Dr. Ruben Ballet, who's really been working on this topic of early intervention in low and middle income countries using very creative methods to show both inequities in terms of knowledge. So what you see over here using methods like bibliometric analysis is that while research on early intervention has exponentially increased, this increase is restricted to high-income countries, which is not where the world's young people with psychosis predominantly live. Similarly, there are only 11 early intervention psychosis programs, or very few programs actually in low and middle-income countries. When it comes to collaborations, which is sort of very interesting, the work shows that the collaborations are primarily between high-income country partners. And the reason this is important is that it could be a channel to address some of these knowledge and service inequities. My own work I've had the pleasure of collaborating with the Schizophrenia Research Foundation in Chennai, India, where we were able to create and support, using research funds, a clinical research program for first episode psychosis. This was funding from the National Institutes of Health. Through that, we carried out about a decade of research looking at the comparatively at the outcomes of young people with first episode psychosis in Montreal, Canada, and in Chennai, India, really documenting in what ways outcomes are different and why they are different. And what's very, very interesting about that is that it resulted in insights that can help advance services and improve outcomes globally. For example, the importance of family involvement, the need to think about service engagement quite differently depending on the context. Now, what is interesting is that what started as a research endeavor, the program has now been sustained and it's a leader in the region and has really continued. So showing that collaboration, and this is something that I hope to continue doing in the future as well. Part of what we're now doing is really thinking about scale and scale in low resource context. So for example, as part of Ruben's PhD, he's also looking at using implementation science to really understand what are the barriers and facilitators to implementing innovations like early intervention in low and middle income countries, specifically Latin America and the Caribbean. Are there some things that make this possible in some contexts? Are there some reasons why some innovations don't scale? So really trying to understand what are the drivers of implementation success in low resource settings. The next sort of theme in moving forward that I would really like to focus on is this theme of deeper understandings of social determinants and mega trends in youth mental health and ill health. And in the interest of time, I'll really focus a bit more on social determinants, but mega trends like climate change, eco-anxiety, the uncertainty of employment, all of these large factors, polarization, also really impact youth mental health and ill health. And we do need to expand our understandings of both services and what is impacting, why the rates are rising to incorporate both social determinants and mega trends. With respect to social determinants, in Access, where we had 16 very diverse sites and where we designed and co-designed services with young people, what we saw with respect to who really came to these services, we found that the group reflected there were about 39% of young people who were LGBTQ, about 22% visible minority, about 35% young people who were not in employment, education, or training, about 40% of young people whose who had difficulty meeting basic needs. So, and these proportions are proportions of groups that have been traditionally underserved. And these are also proportions that are much higher than their proportions in the general population. So really raising some important questions, both about the fact that maybe there is something about co-designing services that made these services attractive to underserved groups, but also other important questions. Do these social determinants, for example, influence the mental health presentations to these primary or enhanced community mental health services when young people come in? Is there a difference based on these social determinants? And this is work that we've been doing, looking at intersectionality in a bit more systematic and nuanced way. This is Dr. Giuseppe, who's a psychiatrist from Italy, who's joined our team and really brings this interest to this area, looking at MIDA models to explore how social determinants and intersections between social determinants might really influence the severity of mental health presentations. So I know this graph is very tiny and you can't see it, but the main purpose over here is to show that considering age, LGBTQ status, ethnicity, and economic difficulties, we identified 48 unique intersectional groups reflecting diverse social positions. And then what we found was that there were substantial variations in mental health severity across these groups. And young adults, in this particular case, young adults from minority ethnic backgrounds and those experiencing financial hardship had the highest predicted probability of severe mental health problems. And the reason this is important is that this analysis showed us that individual social determinants, so additive effects, were important, as well as intersectional effects, suggesting that we would need services and policy action tackling both if we were really to make a difference in bridging inequities. The next sort of question is, okay, so all of these young people are coming, diverse young people are coming. In what ways do we conceptualize services? Are our services currently working? Are they not working? How do we serve these diverse young people? And part of what we're trying to do is really not always identify lacuna or gaps, but come from a strengths-based perspective. In healthcare, there's an increasing interest in looking at positive outliers or like taking an appreciative inquiry approach to figuring out what is actually working. So in this master's project, what we're looking at, it's an example of the kind of work where we are asking young people to nominate. So this is John, who's leading this project, to us LGBTQ young people to nominate for an award service providers they thought provided exceptional care. And then we will be interviewing these service providers to figure out what is it that makes care exceptional for LGBTQ young people, with the idea of then scaling this up in terms of training and capacity building. At maybe one or two last points before I wind down. So with respect to social determinants, the other bit that sometimes we're stuck at either thinking about individual level interventions or system interventions and pitting them one against the other without really thinking about their role or what might be relevant for how can they work together? Do they need to be put together? Do they need to be put together in a certain sequence? So this is something that I think will be important to tease out a bit more systematically than we have in the past. So for instance, in this particular study, we are working with partners in Nigeria, really looking at social protection. So giving some financial savings plus social protection plus well-being and capacity building versus waitlist for young self-employed women in Nigeria to figure out which of these interventions really has an impact on their health, their physical health, as well as their well-being. So really thinking a lot more systematically about addressing and integrating social determinants within our service models. So in conclusions, just sort of like broadly my research program, what I feel is that we can, in partnership with humility, we can really positively change the cultures of mental health for young people in very diverse contexts. And this will require that we have core evidence-informed principles, but that these are essentially owned and operationalized locally, that we're guided not just by science and economics and evidence, but also by values, the rights and voices of people, bringing head and heart together, and that we really need to think in the long term about equity and bridging some of these gaps that I tried to highlight in my presentation. Thank you very much for this opportunity, and I welcome any questions both now and later by reaching out to me. Thank you.
Thank you very much, Dr. Iyer. That was very fascinating, and you're doing such incredible work. So thank you for your presentation. Just keeping an eye on the time, I think we will jump right into our most recent recipient. So Dr. Lipsman was just the 2024 recipient of the Royal-Mach-Gaensslen Prize for Mental Health Research. So thank you for being here with us today, Dr. Lipsman. And you will be focusing on brain circuits and human behavior. So what can go wrong and what can we do about it? So I will hand it over to you.
Thank you very much, Michaela, and a huge thank you to the Royal-Mach-Gaensslen Foundation, the Mach-Gaensslen Foundation, for the terrific opportunity. It was truly an honor and privilege to join you in Ottawa back in December and to join this illustrious list of award winners whose work I admire and truly inspirational. So thank you for the opportunity. So I will share my slides. And let me know if you can see my slides okay.
You're good to go. Thanks.
Perfect. Okay, thank you. So again, a privilege to be here. So I am a neurosurgeon, and I work at the University of Toronto at Sunnybrook Health Sciences Center, where I help oversee a lot of the work that's happening in direct-to-brain interventions and neuromodulation for treatment-resistant neurologic and psychiatric disease. What I hope to do over the next 20 minutes or so is to cover some of the work that we've been doing over the last few years, and some of the different streams of research and investigation, and talk about where we see neuromodulation and direct-to-brain interventions and circuit-based neurotherapeutics headed in the next few years. So, of course, there's a very long line of history going back to really prehistoric times, looking at how we can potentially intervene in conditions of the brain, if you will, writ large. And in a way, this is sort of a journey, a humanity's journey to trying to understand behavior and trying to gain control over conditions and symptoms that are extremely troubling and challenging to treat. Needless to say, the advances that have been made in the last 2 decades dwarf all of the advances that have been made in the hundreds, if not thousands of years before then, much of it driven by advances in technology around imaging and stereotaxy and surgical approaches. But it is a long line, and it is a long line that I think is reflective of not only humanity's pursuit of better understanding of the brain and its conditions and the challenges therein, but also in just how significant a toll mental health conditions in their most recalcitrant and refractory forms can have on patients and their loved ones. So the idea, though, that circuits underlie human behavior is not new. It's been around since the 40s and 50s. And we've known for some time that different regions of the brain can be both structurally connected. So there can be neuronal connections between different sites, which can be single or polysynaptic. But also different regions of the brain can, of course, be functionally connected, where activity in one region ultimately will influence activity in another region. And the work of James Papes and Paul MacLean, who are neurophysiologists, were able to identify key limbic, medial, basal structures that involve the hippocampus and the cingulate that drove and are driving emotional processing. So this concept, this idea that there's a circuit in the brain that ultimately governs limbic associations and emotional processing and how we perceive and respond to emotional stimuli started to gain traction in the mid-20th century. So most circuits that govern human behavior, again, take the same skeleton framework where you have cortical structures that project back to the cortex through the basal ganglia and through the thalamus, through thalamocortical connections. And exactly which cortical structure will map onto which of those basal ganglia and thalamic structures ultimately will determine the nature of the circuit. And the best characterized circuit, and the one that has been studied the most, is the motor circuit, the one that we know is implicated in, for example, Parkinson's disease and in tremors and in dystonias. We know that there are regions of the brain that are, for example, pathologically active in these regions of the brain, specifically in regions of the brain such as the subthalamic nucleus, where pathologic bursting activity is a hallmark of Parkinson's disease. And we also know that different techniques can be used to access those structures. So even though it is a circuit that's comprised of different structures, we know that stimulation or intervention at one key nodes of those structures can influence the entire network. So you don't necessarily have to influence then the whole network. You can just influence key parts of that network that are particularly important and have an outsized influence. And that's what really led to the development of something called deep brain stimulation, which is a neurosurgical procedure that involves implanting electrodes, very fine electrodes, into those very same structures that are stereotactically and really image guided and precisely identified and targeted. And they are disrupted. Activity in those regions of the brain are disrupted through electrical stimulation from a battery that's placed underneath the chest wall. So in conditions like Parkinson's disease, which of course is quite profound in how it affects the motor circuitry writ large, leading, as you can see here, with small amplitude movements, the typical masked facies of Parkinson's, small shuffling gait with several steps in order to turn, stimulation of a 5 millimeter structure in the brain will result in whole-scale changes of that entire circuit. So what we know from metabolic and other imaging, that even though you're stimulating a 5 millimeter target, you're seeing whole-scale network-wide effects in terms of metabolism in the supplementary motor area and the motor cortex and the cerebellum, so quite broadly. So the idea then arose in the early 2000s, well, if you can do that for the motor circuit, can you do it for other conditions as well, including limbic disorders like depression and anxiety and addiction? And of course, as we said, that we have that same skeleton framework, cortical, basal ganglia, thalamic, cortical loops. So implantation in different targets within those, whether it's the cingulate for depression or whether it's the accumbens for addiction disorders, was hypothesized as a possible treatment for highly refractory forms of those conditions. The question then became, though, how do you identify a target? So this is work that was done by Helen Mayberg when she was at the University of Toronto in the early 2000s that found that when you take patients who are medication naive, so who have major depression but are not medicated, or if you have individuals who are healthy and you read them a SAD script, you see hyperactivity in the subgenual cingulate and what's called area 25, so the subgenual cingulate cortex here. And ultimately, when you implant that region of the brain with a deep brain stimulation electrode 3 months after the procedure and then 6 months later, you see a significant reversal of activity in that part of the brain that was correlated with improvements in mood. So this was really the first shot across the bow of using deep brain stimulation as a targeted approach for the treatment of highly recalcitrant major depression. And since then, this work has continued, and including at our center at Sunnybrook, where we have shown over the last few years that when implanted, even at 3 to 6 years after the intervention, patients continue to see sustained reductions in their Hamilton scores, even several years after the procedure. Again, these are typically very recalcitrant refractory patients who have failed standard guideline concordant care, including with ECT and TMS, which are the most common non-invasive neuromodulation approaches. So in terms of DBS for depression, the first patient was really treated almost 20 years ago, or just over 20 years ago. The phase 1 trial, 2005, some of the first long-term follow-up data a few years later. There was an RCT that was finished in 2018 that was inconclusive in terms of its efficacy, but led to a reevaluation of some of the inclusion criteria and launched a recent pivotal trial to reevaluate some of those outcomes in just this past month, which is an American FDA pivotal trial. So we continue this work in other conditions where we know mood disorders are featured very prominently. So one of the areas that we're quite interested in is in eating disorders. And this is the results of a 1-year follow-up trial of deep brain stimulation of the subgenual cingulate in patients with highly refractory anorexia nervosa. This was in collaboration with the Eating Disorders Group at Toronto General Hospital. And what we found in this study was that in patients, again, with highly recalcitrant anorexia, but with comorbid mood and anxiety disorders, we saw significant improvements in Hamilton scores and YBOX scores at 1 year that that occurred before any changes, any significant changes in BMI or weight. And what we argued here is that it was necessary condition to improve in terms of weight to treat the mood and anxiety disorders that we know are highly difficult to treat and that are challenges and stumbling blocks to effective treatment for these very challenging conditions. What we learned from these trials that these are very complex disorders that require a multidisciplinary approach, and long-term follow-up was key in order to ensure that patients continue to be seen and followed. Importantly, we also saw, similar to the Parkinson's work, significant changes in hypermetabolism in parietal regions following the procedure, areas that when you look at the anorexia literature, we see significant hypometabolism in patients that have this disease for a prolonged period of time. Another area we're actively interested in is post-traumatic stress disorder. This is work that was championed by Clement Hamani, who's a neurosurgeon scientist at our institution and who's a translational preclinical scientist, who proposed that stimulating a specific pathway within the subgenual cingulate, specifically fibers that projected through the uncinate fasciculus to the hippocampus and amygdala, would lead to significant improvements in anxiety related to PTSD and fear response. And in a pilot study that was published last year, we were able to show significant improvements in the CAP score by 6 months, and critically significant reversals in glucose hypermetabolism in the amygdala, so in fear circuitry in these regions of the brain. This was one of the first studies also that paired actual real-time neurophysiology with active stimulation, demonstrating significant improvements in skin conductance response in response to a electric-like shock, which we know is one of the illness physiologic markers of PTSD. So promising work from our perspective, because here we were able to show image DTI guided targeting that was paired with a real neurophysiologic response that ultimately reflected a phenomenological and subjective change in symptoms over time. So this work is now being expanded to a larger trial. Addiction, as mentioned earlier, is a major interest of ours as well. This is work done by Dr. Ben Davidson, who is a PhD student in my lab and is now currently one of my partners in neurosurgery at Sunnybrook. Recognizing, of course, that alcohol use disorder is among the most common, costly, and lethal substance use disorders, and that the large majority of patients relapse within a few years, there's an urgent need to develop novel, effective, safe treatments for patients who are really refractory, for whom other treatments may not be available. So here we proposed a pilot trial where we implanted the nucleus accumbens in 6 patients with highly refractory AUD. And what we found that over a 12-month period of time, there were significant improvements in both self-reported and objective measures of drinking, including physician-administered and clinician and interviews with patients as well that occurred over time. Critically, when we looked at nucleus accumbens metabolism after stimulation, we saw significant reductions. Bilaterally, left side more than right. That unilateral finding is something that is subject to further study currently by our group. But this for us was an important illness biomarker, suggesting not only the mechanism of DBS, which is that we may be turning down some of the activity in this region of the brain that we're stimulating that is directly implicated in reward, but also hopefully one day we'd be able to predict before doing the procedure who may be able to benefit from this intervention. One of the newest advances in the area of deep brain stimulation are new electrodes that will allow us to sense activity from the brain. So to actually record activity from the neurons and the population of neurons that we're stimulating in real time. In pilot work that was recently published, we were able to record activity from the subgenual cingulate in response to patients reporting a self-reported depression episode and its recovery. So this for us, it brings up the intriguing possibility that we may be able to detect a neural signature for depressed mood as a kind of marker for the disease to facilitate so-called closed loop stimulation, wherein stimulation is only provided once that signature is detected. This is something that we're seeing in the epilepsy literature and in the movement disorder literature that we hope to translate to depression very soon. So Deep brain stimulation appears to be effective at controlling symptoms of movement and psychiatric disorders, can be used bilaterally, is non-ablative, can be programmed to optimize clinical effects. There will be developments in device size, battery life, closed loop stimulation, and others. So it's an important emerging treatment for patients with refractory psychiatric disease. But there are limitations. DBS is expensive, both in capital and operating costs. It's very resource intensive. There are, of course, the risks of surgery and device implantation. It is designed to be a permanent, lifelong implant requiring programming. And although it's image guided, it's not image guided in real time. It still relies on other measures to make sure that you're being accurate. And at the end of the day, some patients just don't want to have their head opened. They don't want surgery. So alternatives are needed. So in the last few slides, just to cover some of the alternatives that we're exploring, and one of them is ultrasound. Ultrasound has a very long history in medicine, used both as a diagnostic and a therapeutic tool. We know that it has significant advantages over other techniques when you focus ultrasound from multiple sources onto a discrete spot. Because when you do that, you can harness the power of ultrasound energy in order to generate a permanent lesion, where if you harness the power of multiple sources of ultrasound, just like you can with light, you can generate a lesion where those ultrasound waves intersect. And you can do that with very, very fine precision and accuracy. And this is how we use so-called focused ultrasound. This is a helmet-like device that uses 1,000 transducers lined within this helmet in a way to, in real time, focus those ultrasound waves using real-time imaging onto discrete regions of the brain to generate a permanent lesion in a part of the brain that we know is implicated in a given symptom or disorder. We've been doing this a lot in patients with essential tremor, which is a condition that is not degenerative, but is highly disabling. And using this procedure, we can generate a lesion in the VIM nucleus of the thalamus, in this case, treating the left side of the brain for the right side of tremor. And within 2 hours of the procedure, the tremor is gone because that lesion had made a permanent effect, permanently destroyed the parts of the brain responsible for the tremor. And patients go home the next day with a tremor, in the majority of cases, never returning. So when you have this less invasive approach, it begs the question, can we use this approach for other conditions for which historically a lesion has been very effective? And one of those has been OCD. So there's a very long history, a decades-long history of generating lesions in patients with refractory mood and anxiety disorders. Historically, though, the lesions have looked like this: very large, not specific, associated with significant collateral damage to other regions of the brain that you did not want to lesion. With ultrasound, though, we see lesions like this: very precise, very accurate, and atomically targeted to the regions of the brain and contained within the regions of the brain that you want to treat. So as a result, we've been applying focused ultrasound capsulotomy, so lesions in the anterior limb of the internal capsule, to patients with OCD, and have found that in our experience, we've treated approximately 24 patients to date and reported the experience in the first 18 or so to have reached a year. And we see that in the majority of patients, we see significant responses. So by 12 months, approximately 50% of patients report significant reductions in their Y-box in our responders in terms of a 35% or more decrease in their Y-box score. So the advantage of focused ultrasound is you can directly lesion, you can directly see the regions of the brain that you want to lesion, and we can superimpose DTI imaging to eliminate the tracts that we want to eliminate. And as a result, we've become a kind of provincial and national resource for assessments of patients with highly refractory OCD, and are pleased to offer this as a potential treatment, but also investigative tool as we look at not only the safety of the procedure, but also what would potentially predict outcomes after this. So that's where we are now. Where are we headed in the next 5, 10, and 20 years? Well, certainly, I think there'll be more widespread use of neuromodulation for diseases of brain circuitry, certainly with an emphasis on less invasive therapeutics, whether it's with electricity, ultrasound, or magnetism. We're going to expand and refine current indications, looking at new targets, subtypes of diseases, specifically relevant to depression and OCD. Image-based targeting will become much more sophisticated, and hopefully we'll be able to match optimal treatments with patients and their phenotype, and ultimately even their genetic profiles. We want to develop new indications and identify new circuits. And that's where I think I'm very privileged to work at the center that I do. at the Herbert's Brain Sciences program at Sunnybrook, where we recently inaugurated a new building, and at the Hartwell Center for Neuromodulation, where we really try to take as comprehensive and as a team-based approach as we can to neuromodulation. So looking at clinical trials, looking at advanced imaging. We have a very robust interventional psychiatry arm with Drs. Jacoby and Nestor, a focus on image guidance and biomarkers for prediction of response, a functional neurosurgical arm with Dr. Davidson, as well as translational neuropsychology and neurology work with principal investigators in that area. It's only in doing this, I believe, that we can really gain traction in better understanding and developing therapies for the next generation of treatments for these highly challenging conditions that are so difficult for patients and their loved ones. So with that, I want to thank the Royal and the Mach-Gaensslen Foundation for the opportunity, for the recognition, and for your time. And again, thank you and congratulations to all the award winners in your inspiring work.
Thank you so much, Dr. Lipsman. It's nice to hear from you again after hearing from you in December, and I still learned a lot from you this time around as well. So now with that, we have now covered all 10 of our past prize recipients. So I will move on to closing remarks. Unfortunately, Dr. Florence Jarzynski, who is our president of the Institute of Mental Health Research at the Royal and VP of Research at the Royal, she was slotted in to do these but had a last-minute conflict arise, so I am stepping in. So on behalf of the Royal and the IMHR, as we wrap up today's symposium, I just want to take a moment to reflect on what we've experienced together today. So over the past few hours, we've had the privilege of hearing from this extraordinary group of researchers whose groundbreaking work is shaping the future of mental health care. Each of our presenters has not only advanced scientific understanding, but has also directly impacted lives through their dedication, innovation, and commitment to improving mental health outcomes. They've reminded us that research is care and research is actively accelerating care. The past 10 years of the Royal-Mach-Gaensslen Prize for Mental Health Research have been a testament to the power of discovery. Thanks to the partnership between the IMHR at the Royal and the Mach-Gaensslen Foundation of Canada, this prize has highlighted and supported some of the brightest minds in the field. The research spans a wide array of critical areas, and these contributions are not only advancing knowledge, but also changing the way we approach care, policy, and intervention. A sincere thank you to all of our presenters and former prize recipients for sharing their expertise and insights today. Your dedication to mental health research inspires us and fuels the momentum needed to drive meaningful change. Thank you as well to our attendees. Your presence today reinforces the importance of this work and the need for continued collaboration. And finally, we want to extend our deepest gratitude to the Mach-Gaensslen Foundation for their continued support of mental health research in Canada. Your commitment over the past decade has empowered researchers and helped shape the future of mental health care, and we're excited to keep this going. As we conclude, let today serve as both a celebration and a call to action. The past 10 years have brought remarkable progress, but there is still much work to be done. Let us continue to push the boundaries of knowledge, challenge existing paradigms, and work together to ensure that mental health research translates into meaningful, lasting change for individuals, families, and communities. Thank you all for being a part of this special milestone, and we look forward to seeing where the next decade of discovery will take us. So take care and have a wonderful evening.